Hello, everyone, and welcome to Taboo Topics in Parkinson's Disease, a monthly webinar series where we explore topics with stigma attached to them and we try to normalize the conversation. My name is Maggie Ivancic. I am the social worker and center coordinator at UNC-Chapel Hill's Parkinson's Foundation of Excellence and Cure PSP Center of Care. And I'm really glad that you've joined us today, or you're streaming this video at a later date. Our topic today is cannabis and CBD and Parkinson's disease, and our presenter is Dr. Andrew Huang, a neurologist at the University of Rochester. Before we get started, a few housekeeping items. A reminder that participants are muted during this webinar format, but we encourage you to use the chat feature to ask any questions that you have. But please note that this presentation and Dr. Huang's responses to any questions are not meant to serve as medical advice. And with that in mind, we recommend that you do not share any personal health information in the chat, and we encourage you to talk with your own healthcare team with specific medical concerns and questions. With that being said, Dr. Huang, thank you for being with us today and for sharing your expertise with us. This is our most registered for a topic in this series. We had over 50 now people registered. So thank you for sharing.
Thank you so much for having me. I will share my slides. If I can.
Let me know if it's causing you troubles.
There. I'll try this again. Might actually need to rejoin. Let me see if there's any other way around this real quick. Sorry for the hold up. Just going to try to share again. So I will be just right back real quick. So sorry.
No, take your time. See if we can get these technology issues sorted.
All right, there we go.
Great.
All right, so I hope you can see my presentation here.
Yes.
Awesome. My name's Andrew Huang. It's my pleasure to talk a little bit about medical marijuana in the setting of Parkinson's disease. Thank you for the warm introduction, Maggie. I am a neurologist and palliative care physician here at the University of Rochester in New York. And I work in the medical center in our neuropalliative service and division. I'm gonna plan to speak for maybe 40 or 50 minutes, and I have some questions embedded in some cases. So I have a couple times when I've scheduled in pauses to talk about questions, but happy to do questions whenever works best for anyone listening. Just as a brief agenda, I'm going to go through a couple different things. For one, I want to define some of the commonly used terms related to medical cannabis, including recreational versus medical use. Also, the two main compounds in cannabis being tetrahydrocannabinol, THC, and cannabidiol, CBD. And then I also want to talk a little bit about the different formulations of cannabis, and you'll kind of see through some of the cases how they're commonly used. And then I have a frequently asked questions section where I have been anticipating some common questions from patients and families who I've prescribed for and about medical cannabis, among other things. Just as a couple disclosures, this is really my views and practice perhaps, and not necessarily those of the university or of the neurology department. But I think I'm in a group of like-minded souls, so there's some overlap. I don't have any relevant funding disclosures for this, but I do think one disclosure that's kind of important is that I imagine many of the audience may be from North Carolina or other areas, but I'm in New York where medical marijuana and cannabis is pretty widely used, and there is a growing, I'd say, culture of use of it in a lot of clinicians in healthcare. So I think that could be different than some of the other settings that some of you are coming from. So I may sound a little different than maybe another clinician in a state where it's more prohibited. So to jump in, I'm going to talk about a couple cases just to get us all into some of these scenarios. So I want to talk a little bit about a patient named Ryan. I've changed all the names, so these are not actual cases, but these are adopted from real cases. Ryan is 55 and was diagnosed with Parkinson's disease 10 years ago. From his 20s, he was an avid cyclist and hiker and exercised regularly. Unfortunately, around 6 months ago, when he was on a bike ride, a regular bike ride, he fell and fractured his collarbone, and since then has not been able to bike as much and exercise as much. He really enjoys some of the physical therapy boxing classes for Parkinson's. And I don't know if any of you have, that's been a growing trend around the US. But unfortunately spends much more of his time at home than he would like and feels a little restless. His wife, Anne, has noticed that he has been more anxious and short in temper than before. The medication he's been using, that some of you may be familiar with, Sinemet, which is carbidopa levodopa, no longer has as much benefit, and he walks more slowly. He says, I feel like I've lost my life. I worry all the time. My primary doctor tried me on an antidepressant, and I felt really awful on it. I've been losing weight, and I no longer have the appetite I did in the past. And I'm also having a harder time sleeping at night. And he asks his clinician, is there anything that we can do? We'll come back to Ryan and jump into another case. Oops. Let's also meet Jennifer. Jennifer is 45 and was diagnosed with Parkinson's 5 years ago. A few years ago, she noticed that when she would walk, her right toe would curl. It would tighten. And so when she would walk, she would limp. This would last for minutes, sometimes longer. She talked with her movement disorders Parkinson's neurologist about this, and they tried some Botox, which was an injection of a toxin, botulinum toxin, that can paralyze a muscle for many months. But when they tried this on her right foot, it made her very uncoordinated. And so it was not something that she kept continuing to do. When she would get this, what we call dystonia, this tightening, involuntary tightening of these muscles, those muscles involved would really be painful, not only impairing her walking, but it would almost stop her from what she's doing. In one of her visits, the clinician she saw said, well, how are things going with that right foot, dystonia, after we stopped the Botox? She then admitted and said to the clinician, I haven't brought this up to you before, but I was afraid of what you might say. Actually, over the last year, I've been using some of my friends' marijuana. It actually helps quite a bit, but I wasn't sure what you would say. The clinician responds, oh, really? I didn't know that. What exactly are you taking? And Jennifer responds, I'm using a vape pen. It helps the pain quite a bit and actually kicks in pretty quickly, but sometimes I get really dizzy and I get really loopy after about an hour, sometimes even shorter, so I can't really use a lot of it. Both of these cases, Ryan and Jennifer, I hope to help us contextualize medical marijuana and cannabis a little bit, and we'll come back to both cases. So, just to talk a little bit about cannabis, I want to talk about a couple kind of definitions or helpful descriptions about some of the terms involved. So, cannabis refers to any product or compound, typically involving cannabis sativa or cannabis indica. So these are species of the plant. A lot of times when people refer to marijuana, though, they can refer to really any parts of the plant. That could be the leaves, or the stems, the seeds, and even the flower buds. a growing group of people take the flower buds and throw them into smoothies and have a lot of antioxidant effects, for example. But most people, when they talk about medical marijuana and using it as an extract or vape or smoke or any of the other formulations we'll talk about, they're really thinking more about the leaves and something that looks like this, kind of a grouping of a lot of the parts of the plant. Really the flower bud, if anything, at times. Hemp, in contrast, is a specific type of plant that has a low concentration of THC, which we'll talk about is one of the main ingredients, tetrahydrocannabinol. And so just to talk about some terms here. Lastly, what is referred to as regulated adult use cannabis is cannabis that has actually been tested. It'll have a little bit of report like this showing you percentages of some of the active ingredients, but it has been tested. And this is and usually confirmed by each state that allows its use, and is different than an unregulated cannabis that is grown from maybe a friend or a source and has not been tested and is not really being used on a more commercial level, perhaps. So those are kind of important as we'll talk about. Oop, next slide. So further, if recreational use is kind of cannabis that is used from, friends, has been outlawed for many, many years, we'll talk about the history. Medical cannabis, in contrast, is really the state regulated cannabis, not just regulated in its concentration, but specifically used in the context of a medical care provider. And that's kind of how I mostly use it. And that is really specific for certain conditions we'll talk about. And so medical cannabis is an even more specific form of regulated cannabis, which is still yet a more regulated form than an unregulated self-grown plant. From that, there have been a couple lab-grown compounds, these two, dronabinol and nabilone. And these are what's called synthetic THC. It's a synthetic lab-grown version of tetrahydrocannabinol that has been FDA approved for some specific uses. Historically, it first started with anorexia related to HIV, and has also been used for nausea and vomiting related to chemotherapy. So just to kind of contextualize, it's different to have recreational use and medical use. Medical use really has a lot of constraints on it. And on the right here, you can see some pictures of what we'll talk about as oil tincture. And these are drops. You can see it kind of highlights what's in that formulation. And on the top here, you can even see some of the marijuana that's put into a capsule, which we can talk about further, which is a really helpful formulation for many. Further, it's helpful to talk about the two main ingredients in medical marijuana. Thinking as a clinician or as a pharmacologist, medical marijuana really is two different treatments, two different medications. And these two main ones are THC, tetrahydrocannabinol, and cannabidiol. And they have very different effects. So, I mean, practically, they are really treated as like a combination therapy. It would be kind of like for many of you, if you're on a blood pressure medication where there's a combination of lisinopril and hydrochlorothiazide, or many HIV drugs have a combination of multiple medications. Medical cannabis or medical marijuana really is a combination of this. And in fact, this is still simplistic. Actually, in a typical medical marijuana plant or recreational use, there are many more compounds in it that we don't really know, but these are just the main two most pharmacologically active ones. So we talk about these two the most, but there are others as well. And just to kind of give you a little bit of a graph and table to show between the two, we'll be kind of talk about this a couple times, but THC is really more useful for these conditions. Difficulty sleeping at night, really for pain like arthritis pain, nausea. It's also an appetite stimulant. If any of you have had family members who have recreational use, it can give you kind of the munchies, so to say. It really stimulate appetite and make you hungry. In contrast, cannabidiol, CBD, really has history in Charlotte's Web and has been indicated for seizures, refractory epilepsy, and also neuropathic pain. So these two most common ingredients or parts of marijuana are really two different medications. Like they're very two different compounds used very differently. Some of the side effects that are important to know, and there's many more that I didn't list here, is that THC is what, if given at a big enough of a dose, can give you the high that you may associate that if you're on a lot of marijuana to get that high. And some of the symptoms here is it can make you dissociate a little bit, like kind of, I don't know, be out, not quite yourself. You can be a little paranoid. It can give you a lot of dizziness sometimes. It can make you not think quite straight. This rings back to any personal experiences of seeing someone who's been on a lot of marijuana, but that's kind of that's really from THC. In contrast, CBD doesn't have a lot of side effects. It has some, but it can give low blood pressure, but really is tolerated quite well. And I just mentioned this here. I really agree with Maggie that, self-prescribing for these can be a little, difficult slash dangerous, but just to give you a reference range of what is a typical starting dose, just so if you were to go to a dispensary wherever you are and you were to see the concentration of what you're getting, so you to know a typical starting dose for these is something oral is something like 5 to 10 milligrams, or same thing with CBD. And so many different things you can get from these dispensaries. They'll be like 100 milligrams or 500 milligrams. And they can be quite too much for someone who's not used it before. And this is the reason why marijuana use is so different than recreational, because you really are looking at these dosages very closely. So really, just to give you a reference range of what is a typical starting dose, I usually recommend, and that many prescribers do, just to give you a little bit of a sense.
We did
If
get a
there's any, oh
question
yes, sure.
about the difference between, is it nociceptive or nociceptive and neuropathic pain?
So sorry, and that's a little bit of medical jargon, so I apologize. Nociceptive pain is a kind of the type of pain we associate and teach that is like if you were to get a cut, like if you were to get a paper cut on your hand, that pain you feel is nociceptive pain. There are different pain receptors. It's also the type of receptors and pain processing involved with arthritis pain, because it really is the bone, kind of maybe bone with a thin cushion pushing on another bone, that kind of impact pain. Or if you fall and stub your toe, that's nociceptive pain. In contrast, neuropathic pain is we kind of think about as a little bit of a different pathway and process that really has more of brain processing, and it's the nerve pain I think you can associate with if you've ever been sitting in a chair and you hit your funny bone, and that is you hit your ulnar nerve along your arm and you're like, whoa, I got a shock down my whole arm. That's a neuropathic pain. That is the nerve giving a lot of pain signals. Or if you've ever had your arm over a bench for too long and it got numb, and when you repositioned it, or waking up in the middle of the night when your arm is numb, and you can feel the tingling going back in your arm as it gets the feeling again, that's more of like a neuropathic pain. So those two are the most common two big buckets of types of pain, although certainly a simplistic description. Really good question. Sorry, I adapted this from a more medicalized lecture, so I really didn't change all the terms, and I apologize. But yes, THC, CBD are really, really quite different, and they have different uses that we'll talk about with cases. So how exactly does medical marijuana work? There's a lot of science, and I'm sure many of you if you have used before, you may be curious just how this all works. And so this is just a really broad overview. In our body, we have these cannabidiol receptors. And on the right, you can see there's CB1 and CB2. These receptors are really everywhere in the body. You can see many of the locations with these dots of a picture of a person. And I would just direct you that there's a lot of receptors for these different receptors in the brain and in the gut. And that is some of the reasons why medical marijuana has so many effects there, although there are others as well. But both THC and CBD act on these receptors. And actually, I'll say even in 2023, the understanding scientifically of how this all works is not as thoroughly understood as many other things like cancer, chemotherapy, molecular targeted therapy, typical pain medications we use like Tylenol, like opioids. We understand those really, really robustly, not as much with marijuana. And when we touch on the history of marijuana in the US and nationwide and worldwide, we'll talk about how the history has resulted in our understanding actually not being as robust because research was halted for a while. But there are many, many CB1 receptors in the brain. And these are the receptors that when anyone takes medical marijuana or recreational, it affects appetite. Oops. It affects memory. It affects fear, but also can affect things in these receptors in the GI tract, and that's what causes the improvement of nausea, for example, among other things. There have even been some discussions of how having receptors in muscles and also the immune system, these are in the white blood cells in our blood, have actually had anti-inflammatory effects. And there's even been some studies that different marijuana, THC or CBD, may even have anti-tumor effects, like for cancer, but that has not been nearly as well studied. But as we touched on before, really THC, because of the way the receptors are spread out, helps a lot with chronic pain, nausea. It can be a muscle relaxant, appetite stimulant, and CBD really modulates pain and also can prevent seizures. So certainly there are maybe probably thousands of papers now on some of the science, but just a broad overview, I think, if you wanted to think about how this really works. A next high yield topic, I'd say, when I talk about medical marijuana with patients is really the different administration routes. Most medications in medical use, there's one substance and a couple main ways we use it, but medical marijuana really is quite different. There's two main ingredients, and then here there are many ways that you can take medical marijuana. And so they really are so different that it's really worth talking about. Most recreational use uses vaporization or inhalation from the smoked ingredient. And that has advantages because for most people who use a vape pen or smoking it, it acts really fast, like within minutes. It really kicks in quite fast. And it can give symptom relief quite quickly. And so that is a nice thing about the vaporized route. But this is also what comes with some downsides and risks. And this is the reason why so many clinicians are wary of using it. It causes bronchitis. It has some of the same smoke effects of smoking a cigarette. Um, because it acts so fast, it's easy to get intoxicated and take too much. Also, every time you have one blunt and you take an inhalation, it's not consistent how much you take. If you were to take a very long inhalation, you could double, triple, quadruple the amount of a short inhalation. So it's from a medical use, wanting to control the dose, it's very hard to dose control with vaporization. Also, because of the fast on, fast off effect, this is where some of the addiction or use disorder in recent parlance, this is where use disorder can occur. And so I don't really prescribe a vaporize like a vape pen in my practice. Some of my colleagues do. I'm not fully against it, but I have some more hesitancy towards this for a number of reasons. But it's short on and short off. In contrast, if we just talk about an oral version instead, an oral tablet, capsule, or edible, these take longer to kick in. It takes an hour or 30, at least 30 minutes to really, absorb into your stomach, get into your small intestine, and be absorbed into your body, and then go through your blood into your brain to the CB receptors and act. And so, like a typical medication, oral tablet or capsule, medical marijuana in this route takes longer to kick in, but it lasts longer. It can last, 4 to 6 hours depending on the dose, and it will stick around for something like a day, depending on which compound you use. So it really can be different, fast on, fast off, or slower on but lasts longer. Really can be quite a different use depending on if you're using it for nausea or pain. If you have a lot of chronic pain and you're using medical marijuana, you don't really want something that only lasts 2 or 3 hours. You would like something that can last longer and not have to redose so frequently. So really, as a contrast between oral and vaporized, they're just quite different. And we'll talk about through our cases which ones would be worth more useful in one setting or another. In the middle of that is sublingual tincture. That is the medical marijuana purified to in oil. And then they are oil drops, kind of like an eye drop, but that you put underneath your tongue and let it sit there and absorb, kind of like a lozenge, or kind of like if you've done any drops in the mouth that you just stay in the mouth. These take something like 10 to 20 minutes, so pretty fast as well. I really like tincture because it kicks in pretty fast, but it's kind of in between an inhaled form and an oral capsule tablet edible form. Some of the downsides though is it can taste very different and not so pleasant. So depending on, if that's a big part of this. But it can be really great, we'll talk about for insomnia. If you're having someone who's really having a hard time going to sleep and a lot of other typical medications we prescribe don't work, this can kick in within 20 minutes, 10 to 20 minutes, and really help you have relief of insomnia. The last one we'll talk about quickly is there have been a lot of CBD ointments and topical creams, and these can help a lot with neuropathic pain. And the benefit of these topicals, kind of like a steroid ointment or something like that, or a Bengay cream, is that it doesn't really get to the brain. So you don't really have too many worries about having intoxication and feeling really high. So it can be really nice to have ointments for nerve pain or for kind of, ailments that are really in one area. So just to kind of give a spectrum, from inhaled routes to oral to topicals can really be quite a different use of the medication as well, or of the two medications really. So to come back to Ryan for a second, if you recall, 55-year-old has had 10 years of Parkinson's disease, used to be quite the exerciser, but unfortunately can't do as much, and recently has been having increased anxiety, losing weight, and having a difficult time sleeping at night. His clinician certified for him for medical marijuana and recommended that he try oil tincture drops, a couple at night. And the concentration that his clinician recommended was what I would call a more THC focused formulation. That is, there's a 4-to-1 ratio of THC to CBD. That is, in every drop, there was 4 milligrams of THC and 1 milligram of CBD. And when he tried this, I went to the dispensary and tried it and obtained one of these tincture bottles. When he saw his clinician later, he said something along the lines of, "Well, it helped me relax at night, and I can really get to sleep. Kicks in pretty fast. I've even tried it during the day, and when I'm in a lot of panic, it can help me there too. And I've even noticed that I've been eating more because it's made me a little hungrier." Going back to Jennifer, she was our 45-year-old with Parkinson's for 5 years, and also this dystonia, this tightening of the muscles that's involuntary that would affect her walking. Her clinician said, "Oh, that's really great that the marijuana helps. What exactly is in the vape pen?" And she said, "It says that every time I take an inhalation, it's 50 milligrams of THC." And if you recall, usually a starting dose for THC is something like 5 to 10 milligrams. So this is 10 times the usual starting dose. The clinician recommended that she try an oral capsule, a 1-to-1 ratio, maybe once every 4 hours, a couple times a day. Each capsule had 5 milligrams of THC, 5 milligrams of CBD. And then when she came back and talked about her experience, she said, "Oh, I don't get as loopy or dizzy anymore." And actually, the pain control with the tightening of the muscles, it's more even. It's more it's less episodic. It's being on the capsule is a more even coverage of pain. So these are just two cases where medical marijuana could have a role, and two success stories, but among others. And so just to kind of overview these formulations again, it really can be quite different. This is just the same table between vaporized and other forms. And on the right here, I just pulled some images of what you might see if you went to a dispensary. Here is a rather large brownie that has a pretty tremendous amount of THC. And so this is kind of why a lot of doctors are really reluctant to prescribe this. It's like this is many, many times more than a typical starting dose. And if someone is not used to taking a lot of THC and suddenly eats half that brownie, that is a lot. Any the mo Almost all medical marijuana naive patients would get sick eating something this strong. And this is really why it's different than typical medications in the healthcare system because usually nothing this strong would be something available for all patients to access. So it's a little that this kind of scares me. I would wow, that's a lot. That's quite a lot. And here's just a picture of a vape pen and the oil tincture. So you may have had friends or family kind of walk around with some of these things, and you may see it, and it's an increasing use around the U.S. So I just want to pause here for a second, and I know I've kind of covered a lot, and welcome any questions if there are any to chat about or that I've can elaborate on. But happy to move on as well. But just wanted to see.
There is one question from the chat that is CBD a problem for a person who would have low blood pressure?
That's a great question. It can be. Um, it would kind of be like if someone has lower blood pressure, putting them on another blood pressure medication could be scary. So absolutely, it could be a concern. I'd say the cases, I don't think I've ever seen a case actually where someone on just CBD has had really low blood pressure. That has mostly come from some of the trials we'll show where there has been some. I'd say, I've had patients on, 100 milligrams of CBD at a time for neuropathic pain and capsules and have not had that. So I think it is a rather rare phenomenon and side effect. But if it did happen, then that would be a reason to stop it. And just like if someone's getting worse in hallucinations on THC, it's a reason to stop that dose in that form. So absolutely, it can happen. I would say more rare.
Okay. Another question that came in is, at these starting doses, would there be withdrawal issues after being used for an extended period of time?
Such a great question. I feel like I almost planted that because that's one of my frequently asked questions, but happy to talk about that briefly now. At these starting doses, there is very little risk of a withdrawal phenomenon. I'll have a couple graphs later that show the most typical withdrawal symptoms, but short answer is no, not at these doses. There's such small doses we start with to really be precautious that there's very minimal side effect, minimal risk of that. I'd say the typical doses where I've had to talk to my patients about withdrawal is if they're on THC like 50 to 100 milligrams at a time, then I say, gosh, your brain and gut are very used to a lot more THC and those CB1 receptors, and we need to be a little precautious about suddenly stopping them. But at 5 milligram, 10 milligram levels, I have not seen it.
There is one more question, and this
Yeah.
may be a difference between New York and North Carolina, but this person asked, my understanding is that medical marijuana or any product over 0.3% THC is not legal or available. Assuming that is still true, how does that affect your recommendation?
Absolutely. As far when I researched for this, giving this talk, I looked into what the laws are for North Carolina, and I saw that as well. I heard there was the North Carolina House had passed a law for trying to bring in more medical marijuana, but it had not yet passed the Senate as of 2022 and 23. So that is what I was reading online that typical THC-focused products that have more than 0.3% are not currently allowed in North Carolina. And that is very in contrast to here, where there's 5 dispensaries within a couple miles. So absolutely. I think it really, if I were practicing in North Carolina, it would feel very hard, I can imagine, to prescribe given the current legal circumstances. Um, so absolutely.
Um, and maybe we'll have this be the last one before we move on, but does the effect on nausea relief affect peristalsis or different receptors? Asking because Parkinson's patients have so much constipation.
Great question. So in Parkinson's, constipation is such a common phenomenon. The majority of patients have difficulty with constipation, and peristalsis is the medical word for the gut, really the large bowel, kind of squeezing to push through different things in the body. That's the peristalsis. It's a rhythmic process that kind of gives you the sensation that you may need to have a bowel movement. And the peristalsis is commonly slowed in Parkinson's for a variety of reasons. So, nausea related to peristalsis is alleviated by THC. Kind of similar to if anyone's taken Zofran or Compazine or Phenergan, they also have this kind of relief of nausea. But I am not aware of THC's effect on the peristalsis itself, but on the sensation it gives, it does help with that.
Thank you, and we'll keep that
Absolutely.
going.
Yes, please. If we didn't get a chance to address your questions, please keep them, and we'll come back. And maybe I might cover them in the frequently asked questions section too. So we'll see about that. All right. Okay, so I imagine some of in the audience may have Parkinson's for longer as well. So I thought of this case as another instance I've used it. Let's meet Bob. He is a retired firefighter, 70 years old, and he was diagnosed with Lewy body dementia 2 years ago. If some may be unfamiliar, Lewy body dementia is one of the Parkinsonisms. We call them like the atypical Parkinsonisms. And that is, it is a cluster of conditions that have some features of Parkinson's disease. That is the slowed movements, we call it bradykinesia, can have tremor, can have decreased walking speeds, similar Parkinson's features, but also have other symptoms. So these atypical Parkinsonisms, like Lewy body dementia, has a lot of dementia and cognitive impairment, has a lot of hallucinations, among other things. So Bob, unfortunately, was diagnosed with Lewy body 2 years ago. His wife, Julia, helps to care for Bob, helping him get dressed, making meals, finances. And Bob, like many with Lewy body, faces hallucinations. These hallucinations with Parkinson's and Lewy body tend to be animals, people, usually in the periphery of vision. And for Bob, it's outside the window, especially at night. He thinks he sees someone, and when he looks there, he doesn't see anyone. He's been having a harder time walking. He has been falling downstairs. Um, his memory has been also a challenge, and he sometimes forgets that he is at home. At Julia's insistence and request out of love is really trying to get Bob to use a cane or a walker to prevent some of these falls. Mostly Bob uses a cane at home and then a walker when he's outside or out and about. But in the last couple of months, Bob has been getting more and more agitated. He will suddenly get out of his chair and forget to use his cane. He might think he sees a squirrel or a child outside and go check to see who it is. He might, in the middle of the night, have to go to the bathroom and just urgently want to go to the restroom. And he can sometimes be very agitated, enough to where Julia has a hard time consoling him. At one point, Bob was so agitated that he ended up bumping into Julia, who fell and hurt herself, bruising herself. On another occasion, Bob was very sexually aggressive at night. And these are phenomena with dementia that are actually not very rare, unfortunately, and can be quite a challenge for the family and as well as for any clinician trying to care for both of them. In response to this incident, Bob's geriatrician tried some medications to help with the agitation. He tried an antipsychotic medication called Seroquel. That is the company name, and the common generic name is quetiapine. And this is a second generation antipsychotic, and this was used to try to help with agitation. But one challenging thing is when Bob gets very agitated, a lot of times Julia can't convince him to take it and would, encourage him and give him cues and ask him to take this to help calm down. And then when Bob does finally take the Seroquel, it takes half an hour to an hour for this medication to kick in. So it can be not ideal, not effective enough, even though it's worth trying and it can help with some agitation. Um, the clinician who sees him asks, okay, well, maybe is there anything else you've tried that has worked? There are other medications, but are there ones you've already tried? And Julia says, oh, one day I was so desperate, I gave Bob some of my son's marijuana brownie. It did make him sleepier and help him calm down, but it also worsened his hallucinations. So it wasn't quite a success. And so this is a very common occurrence that we see with all dementias in our neuropalliative clinic, but especially with something like Lewy body dementia where hallucinations are so common. So what we ended up trying is we tried oil tincture instead of the edible. We went to it with a 1-to-1 ratio of THC to CBD, used a pretty small starting dosage, 5 and 5, and we used this instead. Julia told us he was more willing to do oil drops because I would always give him ice cream as well. And they kick in a bit faster. It doesn't take an hour or 45 minutes, it takes like 10 minutes to kick in. And because it's a lower dose, it did not really worsen his hallucinations. So it was a little more effective. And after we used this more, we tried increasing the dose a little bit. I think we went up to maybe fit like 3 or 4 drops, something like 15 to 20 milligrams at a time. But that would usually do the trick. Certainly not a cure, certainly not, maybe more of a band-aid in some way, but a more effective one than some of the others, and a nice option and a tool in the toolbox. Um, there have been some studies of medical marijuana for agitation. And here's one of them. This was a randomized controlled trial of one of the synthetic THCs in Alzheimer's patients. And this is a graph that shows some of the results, but they used the synthetic nabilone, which is equivalent to the typical starting doses of THC, and they compared in one half on nabilone and another half on placebo. And they actually crossed them over in the trial, but they did this over a couple of months. And in red is the percentage of patients with these results, these changes of placebo, versus in blue of using nabilone. So not slam dunk results, but you might if you kind of just compare the blue and then the red, you might see there's a little bit more blue in the more improvement results than in the red, but certainly not dramatic results, unfortunately. But you might appreciate that there was for some people, this was pretty effective. But again, certainly just another tool in the toolbox. And I think this might be a good time too to just emphasize that as many of you know, maybe better than me, that Parkinson's is not just a movement disorder and can have so many of these of non-motor symptoms and care needs that go so much beyond just having tremor, for example. And so this is the 5 pillars of palliative care in Parkinson's that talk about non-motor symptoms like hallucinations and agitation, Supporting the care partners. I imagine some of you may be care partners in the audience, and supporting your health and well-being is so crucial in this. Additionally, for both care partner and patient, the emotional and spiritual needs are hugely important. Depression, caregiver burnout, and then also important to just think about the future that may come and refer to specialist teams as needed. So this may not cover all the needs, but certainly some big categories in comprehensive Parkinson's Centers of Excellence. I'll just briefly chat a little bit about. Oh, I think there may have been a question, so I can pause. Totally up to you, Maggie. But yeah, yeah, happy to pause or keep going, whatever you think is best.
Um, are there some specific symptoms of Parkinson's that you would look to consider recommending medical marijuana?
Yeah, really great question. The most common ones I use for Parkinson's, I'd say, is insomnia, anxiety. I don't get as much nausea with Parkinson's and other conditions, but I'd say insomnia, chronic pain, anxiety are probably the ones that I use most commonly, and then some like this neuropathic pain, like dystonia or other neuropathic pain. A lot of my Parkinson's patients may have a herniated disc and have some shocks going down one leg from the past, and that I'll use it there as well. But I think if I just had to pick two things, I'd say insomnia and anxiety have been some of the most common reasons I've used it, along with kind of just like mood in general. Um, but uh, but yeah, I think there have been many others, but those are probably the most common. I land on.
Mood and sleep changes. Yeah, those are very big. And another question was in North Carolina, there's no THC sold, but we have Delta 9, 8, and 10. How are these different?
Yes, good question. The other variants, the Delta 8, 9, and 10, I don't use them as much, but I know a little bit about them. Some of the products we have some of those. Many of them share some effects of THC, being that it can help with nausea, it can help with appetite stimulant, it can help with insomnia. But many of them have less receptor affinity or CB1, so they're kind of like less potent versions of THC. So I think some of them may be different, but many of them are similar THC in terms of I'd say their clinical use.
Thank you. That's all the
Yeah.
questions for now.
Yeah. So what has been done from the medical side about medical marijuana movement disorders? I think this is a question that comes up from a lot of patients I've heard. They'd say, has it really shown? So here's a table of some of the clinical trials done in the last, I'd say, 15, 20 years. Here are some dates of when they occurred. Here are some of the number of people in those studies, the duration of these studies, not a long, long time, and then some of the formulations they used. So CBD really more for like neuropathic pain, or they tried it for motor Parkinsonism. Some of the others like Nabalone really are more like THC, but and they have the design and some of the results. Kind of notable, I'd say, is for one, this is not that many. And this can point to the history we'll talk about of marijuana research in the US. But this is not that many trials. They're very small trials. And moreover, a lot of the results were not that impressive. So I think a couple takeaways I'd say from some of these studies is that there's not been a lot of research in medical marijuana in terms of clinical trials. And secondly, the results have not always been that slam dunk. So this is also some of the reason why movement disorders clinicians or many geriatricians and primary care physicians do not feel very enthused about using it. And so to be very, I think, fair to the literature and fair to the research so far, it is not as though this is a slam dunk approach or a topic, and maybe why many states still have not, it's not been a very widely used thing. But I think that is kind of the science side of it. And then I think on the other side of it, you might say, gosh, I have so much personal experience. My family members, my kids have tried it, where there's been some benefit in some areas. And so I think it's different than like Tylenol, which has had just, century of proven track record. This is not like that. Medical marijuana has a lot of pros, has a lot of cons. In some settings can be useful, but in other settings, really not that useful. So, I think I was thinking about this talk, and the last thing I want to do is come in and be so gung-ho about medical marijuana. I certainly have a lot of hesitancy sometimes. And we'll talk about, like, specifically one reason is the age group that this should be used in. And we'll talk about that too. So, just a little bit about the history of marijuana use. Back in the 80s, and some of you may have been more personally witnessed to this more than me, um, there was a lot of political energy against the war on crime, the war on drugs. And for example, there was this Anti-Drug Abuse Act, and this instituted mandatory sentences for drug-related crimes. There were some in some of the sites I was reading, they used to associate having 100 marijuana plants, like having it at home, equivalent to having 100 grams of heroin, like that in terms of equivalence of punishment or being an illegal thing. And there was this three-strike policy where you could get a life prison sentence for having possession of marijuana. So this was quite an aggressive, I'd say, stance to the point that there wasn't that much medical research on medical marijuana because it was considered such a Schedule One drug equivalent to heroin, and I think this made it hard for medical use as well, I'd say. And then I think it's because of this history that it took so many years for states to begin to use it or find a specific medical use. So, for example, is 1996 is when medical cannabis was first legalized in California. Many states followed in the coming years, and then in the next decade, a good third of states. Um, for example, I looked up that North Carolina only in 2014 had the low THC, high CBD law, which I think some of you mentioned. There are some high CBD hemp products that are allowed. And then I mentioned earlier, I was seeing that it was the Senate, not the House, had passed a bill to legalize medical marijuana, but it was not fully through the state. So I can imagine for some of you in the audience, if you're living in North Carolina, you're probably living in a very different climate towards medical marijuana than New York or Colorado or California. So I have a series of frequently asked questions, and maybe I can kind of pause, but we can go into these too, however is helpful. I saw there may have been a couple questions. Let's see if but welcome. Yeah, talking about that.
Yeah, the one question was how, and we've talked around it a little bit, but how does cannabis affect the neurology of a Parkinson's patient specifically?
Good question. Yes. Out of these studies, the general consensus is that using medical marijuana or recreational marijuana does not significantly affect the actual disease process of Parkinson's. It may be worth noting, kind of a neurology side note, the full process pathophysiology, we say, or of Parkinson's, or like how it all manifests is not fully clear. One of the leading hypotheses, um, well, what we do know is invariably Parkinson's leads to neurons in the deep part of the brain that affect movement, that those neurons start to malfunction and die. There are many hypotheses for how that happens. One hypothesis is that Parkinson's is kind of an infectious disease. Something in the water or in the environment, not clear, is absorbed through the gut. When whatever that carcinogen or pathogen gets into the gut, it causes the gut to not function, giving constipation. It then rises through the spinal cord, and when it gets to the brain stem, and it gets to the deep parts of the brain, that's when you start to get the motor symptoms like tremor, bradykinesia. And then when that process gets all the way to the out of the cortex of the brain, that's when it causes dementia. So there's kind of this progress of symptoms that many people associate. Other people deny that whole hypothesis and just focus on specific neurons in the brain that are lost and are seen in pathology, and that just causes the motor symptoms. All of that is to say, the CB1 receptors being on medical marijuana does not affect that process, not that we know of.
Does it affect dopamine?
Good question. So, not necessarily. The dopamine in the motor neurons is used as a messenger for moving our arms, our body in space. So it does not really known to affect that. And some of these studies here had no change in the dopamine parts of the brain when they trialed different medical marijuana products. So not really. It's worth also saying that dopamine is also the communicator used in other parts of the brain for substance use disorder. So it can affect dopamine because there are some individuals who get an addiction or cannabis use disorder, and that involves dopamine, but not dopamine in the Parkinson's sense of you moving your motor function, moving your arm in space, and things like that.
Those are the only questions at this time.
Sure. So, other common questions I get. So, can I take more than the initial dose? I'd say big picture, this kind of comes to the comfort of the clinician who is recommending it, but we start low for a reason. But I will say I do treat medical marijuana kind of like I treat Cinemet. So for many of you, you may have asked your doctor, like, can I increase my Cinemet? And it's kind of like yes and no. Like, well, we try to keep it at a low dose because we know if you increase too high, there can be some downsides. At the same time, some people with Parkinson's need a higher dose. And so certainly everyone's body and brain are different. So for some people, you need more than 5 or 10 milligrams of THC to get a benefit. So overall, I've been pretty open to my patients increasing the dose, and I've kind of followed their lead, just as I do with Cinemet. If I think if someone comes back and says I'm still really rigid, then I'll probably want to increase your Cinemet, and I take the same approach with THC and CBD. If it's not working, I will try a bigger dose. But as soon as someone says they're getting like any sort of dizziness or the high of THC, that's when I stop. What happens if I take, I think someone maybe asked this earlier, what happens if I take medical marijuana or recreational marijuana excessively or very regularly? Like, what can happen? This is a graph of the receptors, the CB1 receptors we talked about, and what we call tolerance. Tolerance is a phenomena in any medication where if you take that medication enough at a significant dose, at a significant frequency, your body and brain can get used to it. The receptors involved will start to get adapt to the exposure to whatever medication it is. And so this shows a patient, from their study in their blood levels of their response to cannabis as they take cannabis, medical marijuana really frequently around the clock, the effect is lower over time. How long it takes to get this tolerance effect can be variable, but certainly taking a high dose frequently that has a short half-life, like inhalation or smoking, can lead to tolerance. Where if you took 10 milligrams, it used to have this effect, and now it has this effect in your brain. And then you can see the difference if you have different dosing. So if you space out the dosing, but still a high dose, you may not have as much tolerance than if you were to take it really successively. So that's kind of like some of the difference here between the dosing. So you can have tolerance. It happens with everyone. But if you take it less frequently and at less of a big dose, it is less likely to happen. Another question I get is, gosh, if I'm on marijuana, will I get addicted? Will I have use disorder? So this is just a couple graphs. On the right side shows you a relative proportion of some of folks who don't use any medical marijuana or recreational. someone who uses a little bit, probably maybe socially, versus someone who is escalating, using it quite regularly, versus situations of using it harmfully or abuse, or we would say abuse, or you, and then actually being dependent and having full cannabis use disorder. And the criteria of cannabis use disorder, like alcohol use disorder or cocaine use disorder, are shown here on the left. So, for example, it really requires that the individual is unable to cut down and stop. They're spending time obtaining because they feel their body getting in withdrawal. There are cravings such that there are hazardous situations. Like some folks with opioid use disorder will really feel so driven to obtain opioids, they will break into people's houses. So these are really the symptoms, and this is really pointing to this upper category here. All of this is to say, this is the criteria. It's a really rare phenomena, and for most people with Parkinson's where we use it, we never go anywhere near this far. It's a pretty rare occurrence to have cannabis use disorder in the Parkinson's population. I'd say being one of the more open marijuana prescribers in my kind of institution here, um, I don't think I've had anyone I know of so far in my time who has really progressed to use disorder. Our use is just such a small dose, relatively infrequent in settings that it's not really, doesn't arise to this sort of level. So, short answer, I think it's really unlikely for Parkinson's, but possible. What if I suddenly stop taking it after I use it 3 or 4 or 5 times a day? And I'm just showing a couple graphs here of what the withdrawal symptoms look like. So if someone's on like 50 milligrams of THC 4 or 5 times a day and they were to suddenly stop it, these are some of the symptoms. You can get insomnia, kind of a flu-like syndrome. Can feel irritable, anxious, and can affect your mood as well. Some people can get a little bit of tremors and some cravings too. So these are the typical syndrome, but um, yeah, I think for most people who use a good amount, they kind of have experienced it and would not stop all of a sudden. Another one I get is, okay, what does the intoxication look like? Like, what if I were to accidentally take the whole bottle of tincture on accident, which no one recommends, but what if? And the typical symptoms of marijuana intoxication is this kind of euphoria. Really, you can have a lot of hallucinations. Um, I will say there have been a lot of studies, and all in studies from the ED, and almost with very few exceptions, um, marijuana intoxications are not lethal. There is something with the brain where there are not enough CB1 receptors in the brainstem that affects breathing. So almost no one with marijuana intoxication has really morbid, scary things in the ED where you need a breathing tube or you need a lot of ICU care. It's mainly just because you don't have enough CB1 receptors in the brainstem. So, not that it's safe to do this, but compared to alcohol or opioids, which unfortunately kill hundreds of thousands of people every year, marijuana is not like that. Another topic that's somewhat important is what are the long-term consequences if I were to take marijuana quite frequently, for example? And this is where there has been a lot of research. Marijuana use in adolescence has been very clear. There is a strong association in adolescents who have early, frequent, and heavy cannabis use that it affects cognition long term. I've read a couple studies, it's something like it actually lowers IQ by 10 or 10 to 20. So if I have a younger patient, I almost no matter what the symptom burden is, I almost never prescribe medical marijuana for someone I'd say below 40 because there is a known effect that the cannabis use, especially in development, but even I'd say in young adult age, can affect your cognition. I think though, because most Parkinson's patients or Parkinson's and related disorders tend to be older, and especially I think if they're in their 60s or 70s, um, this has never been shown in that population. So with the younger patients, I tend to avoid medical marijuana, but in a patient of an older age, there has not been any studies showing an effect on cognition. If anything, there have been animal studies showing that in animal models of an older animal, older rats, older mice, they do not have any effect like that. So my short answer is there are long-term consequences for adolescents, but no known for adults, older adults. I think there's one more. Nope, I think that's the last FAQ I had, but I'm welcome to talk about other questions too if there are any. But yeah.
Yes, we welcome if there are any other lingering questions for you to add them in the chat. Thank you so much, Dr. Huang. I love the FAQ section because you took all the questions that I that I had written down. So I'm curious if any of the rest of our audience has anything to add, but I think that it was such a good and well-rounded presentation. Thank you so much for sharing with us.
My pleasure. My pleasure. Let's see, I'll check chat.
Yeah, how is a tincture applied?
Oh yes. I think by apply, I imagine they mean how's it used. The most common way that I've had patients take it is they at nighttime they'll just kind of like as if you're eye dropping, but just drop it underneath their tongue, and just be a couple drops at a time. Um, I usually say try not to swallow it. It's totally okay if you do, but it's more effective if you kind of leave it on the bottom of your mouth, kind of like a cough drop. Like if you have a cough drop, like you could swallow a cough drop, but it's kind of meant to be in your mouth and like affect your throat if you have a sore throat. So similarly with the tincture, it's intended to be to dissolve and absorb through the sublingual mucosa. So I usually say a couple drops beneath your tongue before you go to bed, see how that goes. But really only a couple drops. Start low.
Okay, under the tongue. Um, CBD is not regulated in North Carolina by the state, so we can get a certificate of analysis provided by the seller, but it may be generated by an independent lab. So we have to buy from a reputable shop or processor. Some sell CBD isolated and some sell plant extract, which supposedly contains many different cannabinoids. Um, Losing my place in the question. And sold as being better. Do you have an opinion on extract versus isolate?
Yes. Okay. And I think I just managed to pull up the question, so I'll try to make sure I can. Um, yes, here in New York, we have our institution has landed on a couple dispensaries that we mo use most. So that is to say, I generally lean towards extract because you kind of have the report of how much is in there and it's been tested. So the products that that my patients get from those dispensaries are usually based on extract. Like it's an extract turned into an oil, a tincture. Um, but I think with that said, given if you're in New York, North Carolina, and the medical marijuana programs have not been as developed per se, I could see that you might find the other versions okay too. I'm seeing um, I think what it means to be reputable is kind of hard if you're in North Carolina, if there's not like a state process that's reviewing them all. I think it's really hard. So I would say if I had to pick, I'd say CBD isolate, but I guess it would be hard to know, versus this plant extract that you're mentioning. Um, but if the plant extract has a lot of these other cannabinoids, it's really tough. Like you don't know what you're taking. It's kind of like there's a lot of other ingredients and it's really hard to say. So from a like being a pure clinician, wanting to be one compound in one administration. I'd really want there to be one thing, or CBD and THC, but I think it not necessarily, the other ones could possibly be okay.
And just so all of our participants know, yes, this is being recorded right now. We will send it out to everyone next week, so you will have the chance to review. There's lots of good information. That is all I'm seeing in our chat right now for questions. Thank you so much for taking the time to talk with us and for being so thorough and answering the questions throughout and having the questions embedded in. We really appreciate your time.
Thanks for having me. It's my pleasure, and yeah, happy to email if others are in, and happy to chat more.
Thank you. I am stopping the recording.